Okay, welcome Kim to the Biohacker Babes podcast. Thank you so much for joining us today. How you doing?
Great. Nice to see you guys. Thanks so much for having me.
Yeah, so nice to have you here. We're talking about vaginas today. There's no way around that. That is the topic of the day. And a lot of people are not talking about this
Yeah,
nearly enough. And I think pelvic health in general is like usually only talked about maybe after childbirth or if something goes wrong. But we know in this space, so much needs to be preventative, ideally.
1000%. Yeah,
Yeah.
yeah.
So we're going to talk about how do we be proactive about our vaginas and our pelvic floor health today. But I'm curious to kick it off. What conversation do you feel like women need to be having about our vaginas that we're not currently having?
There's a lot of conversations that need to be happening that aren't happening. And I will say that, so I've been in this space for 21 years, and every day I'm still floored and no pun intended, I'm still floored that uh, that people haven't heard what I'm talking about. I feel like I've been saying it for a long time. There's other people that are saying it, but it just still is a bit of a taboo topic. I will say though that in the last 5 years, social media has definitely played a role in increasing awareness. And even in the last, I'd say like 6 to 8 months, I've seen a lot more people realizing that pelvic floor is having a moment. A lot of that is due in part to the explosion of the conversation around menopause. And so there's a lot of other people now bringing pelvic health into, especially people who are working in the fitness realm, bringing it into their conversations. So the first of all, we need to understand that we even have a pelvic floor. We have that terminology is never used at any point in any conversation about menstruation or when we learned sex ed in school, when we learned about our bodies, there was nothing about pelvic health. And really all we learned about was this is the menstrual cycle and here's what you need to know about not having a baby, like the STDs and birth control conversation. We need a lot more information than that. And I think that's the perfect opportunity for us to introduce the concept that whether you have male or female anatomy, you have a pelvic floor. People with female anatomy are at greater risk for pelvic floor challenges because we have a menstrual cycle, because we have hormonal fluctuations, because we have a different shape of our pelvis, and we have a vagina, and we have a uterus, and most of us are pregnant at some point in our life. And then if we live long enough, we're all going to go through menopause. So there is a lot more information that we deserve much earlier in life. First of all, our anatomy, the function, that it's a group of muscles that need to be trained like the rest of the muscles in our body, and then expand upon what most people have probably heard of, which is do your Kegel exercises. And I want to pay tribute to Dr. Kegel, who even started the conversation or the concept about exercise for the pelvic floor. But we need to we need to expand on that, and it's limiting in the sense of it's a static exercise that is boring, that most people we know from research do incorrectly. Not their fault. Nobody's ever taught them how to do it correctly. But also, it's not training the pelvic floor dynamically for real life situations. We're not training it with the principles of fitness. And so that's something that we need to get out in the mainstream for sure.
Hmm. Yeah. So why do you think it's not in mainstream? Is it like lack of education? People don't think it's important, or is it more like, oh, it's kind of taboo because it's in that area of the female body and we don't want to talk about it? Or is it
Yeah,
both?
I'd say it's a little bit of both, but more so the latter. And I would also kind of like how women weren't included in research because we're too complicated, until whatever it was, 1993. I think it's along the same lines. Like it's not something that people want to investigate because it feels awkward, it feels embarrassing, they don't know what questions to ask. So part of what I have a certification course, and part of what we do in that is teach people who are working with women in a fitness capacity how to have these conversations as part of their screening. All of us are doing some sort of a screening before we start working with somebody. We need to have questions about bladder leakage. We need to have questions about pelvic organ prolapse, about chronic back pain. How many children have you birthed, if any? What stage of life are you in? Have you fallen on your tailbone? Questions that seem like, why would I ask that question? But why is that relevant to how I'm going to ask them to do a squat or a bench press or whatever it is? But the pelvic floor is so central. It's the foundation of our core. It's where we drive our power from. When things are working well, We don't even think about it. Nobody thinks about it. But when it's not working well, it's one of the only things we think about because it affects our continence, it affects our sexual response, it affects our ability to and desire and capacity to do certain exercise. We know that 46% of women stop exercising because of their pelvic floor. We also know that a sedentary lifestyle is a contributing factor to pelvic floor dysfunction. So there's a huge disconnect there where they're stopping either because they feel symptomatic or they think it's going to make things worse, or they've been told by a healthcare professional, you can't lift anything over 10 pounds. You can't jump or run anymore because you have this condition. And so they are then now sitting there thinking, okay, especially now the world is saying to all women, you have to do impact and you have to lift heavy. So the people who have been told not to are like, what do I do? So I think it's a whole host of things. But a lot of it is lack of education and also the fact that it is historically been a very taboo topic, uncomfortable to talk about.
Yeah, I
Yeah.
just want to say from personal experience, I've seen so many physical therapists in my life due to dance injuries. And I've had one that has even gone remotely into that direction of looking at pelvic floor. And it was uncomfortable. And it's amazing that we're getting more education around this, but I think also with sensitivity culture, it becomes a little contradictory. The
Mm-hmm.
purpose was like, is this okay? Can we do this? I'm like, well,
Mm-hmm.
if it's part of my health and my body, the answer is 100% yes.
Yeah. And with pelvic PT, well, sorry, with regular physical therapists, many of them once they understand and learn pelvic health, not everybody wants to become a pelvic health physical therapist, but once they even just learn that, they now have this new appreciation of what's been the missing link for so many of their patients who they just could, chronic back pain, chronic knee pain, hip pain, incontinence, all these issues they couldn't necessarily address. And it's so often the pelvic floor is the missing link. So again, not all of them choose to go and get trained as a pelvic PT, but once they at least have that understanding, it should be standard information shared in personal training certification, fitness certification, physiotherapy certifications. It should be part of at least the conversation. And then people who choose to add that as a skill can go and take additional training. But yeah, so many people just don't know the link.
Yeah, absolutely. I agree. And even as a personal trainer, which I've done for a very long time, that was never part of my training at all.
Mm-hmm, mm-hmm.
Yeah,
Still isn't.
we learned Kegels, we learned how to activate your TVA, but it's like this whole part of the body is just ignored completely, which is wild. So I'm really
Yeah.
curious to get to your method and how we can actually retrain and strengthen here. But if we were to zoom back to root causes, can we kind of go through some categories of why is this even happening in the first place? Maybe
Mm-hmm,
for a young female, our audience is primarily 30s, 40s, maybe they haven't gone into menopause, maybe
mm-hmm.
had a child, maybe not. What are some of like the big categories that could be causing this?
Yeah, there's a misconception that you have to have given birth and you have to be older or elderly to be experiencing pelvic floor dysfunction. And this can happen to anybody at any stage. You don't ever have to have been pregnant. A lot of things like, so we know from research that chronic, repetitive, high intensity exercise is a challenge for the pelvic floor. And it's not to say that high intensity exercise is bad and women shouldn't do it. But again, if we had this information earlier in life and we understood how to bring the awareness of our pelvic floor, how to breathe appropriately, how our posture plays a role, how to manage intra-abdominal pressure, and if we had we just like we have bicep training, just like we do a leg day or an upper body day, we need pelvic floor exercise, and we do have research to show that as well. That if we compared somebody doing pelvic floor exercise and sort of whole body fitness versus somebody doing just whole body fitness, that's not enough to address the pelvic floor. We need specific pelvic floor muscle training. So I think that's one thing is we need awareness, we need education, we need training for the pelvic floor. So a root cause could be lack of awareness. Posture, we know posteriorly tilted pelvis. So if you have more of a tucked tailbone, or if you have more of a upper hyperkyphosis, if your upper back is rounded, we know that is also an increased risk factor. We know that chronic coughing, dehydration. So people think that if I drink more water, I'm going to have to go to the bathroom all the time. So people who feel like they're always going to the bathroom will start limiting their fluids, thinking that's going to help. And then the urine becomes more concentrated, and now the bladder becomes irritated. It wants to get that out. So it's going to signal you more urgently and more frequently. So dehydration is going to play a role. A really, really big one is constipation. So constipation is, a lot of people struggle with constipation. And when we have, there's a couple of elements there. If we are not eliminating, so if we have stool that's trapped in there, that mass is going to put pressure on the bladder. It's going to make you feel like you need to go to the bathroom, urinate more urgently, more frequently. Also, if you have difficulty emptying, difficulty in your straining, that strain and that pressure is also going to be downward pressure on the pelvic floor, could potentially influence the nerves of the pelvic floor. So constipation and dehydration are always the first two things that I will address with somebody, because we could change your posture, we could give you all the magic exercises in the world, but if you are chronically straining to poop and you're dehydrated, you're kind of going to have a one step forward, two step back scenario. The other piece would be bladder irritants. So there's the common list of alcohol, caffeine, artificial sweeteners, just regular sugar, dairy for many, gluten for many, acidic foods, spicy foods, carbonated beverages. So that's not to say that all of those will be an irritant for every single person, but doing a bladder diary and understanding that some of the triggers or the symptoms you have might be because of what you're consuming will give you appropriate and good information so you can then make choices about what you're eating or drinking. So those could be that's another important part that a lot of people don't necessarily know.
Yeah, like a checklist. We can go through these and figure out what the lowest hanging fruit is at least.
Yeah.
Okay. Yeah. Oh gosh, I have so many questions. I think just on I'm the worry pee just in case pee girl.
Yeah.
And I just recently learned that is not a good thing. Like,
correct.
I'm going to pee just in case. If I'm getting on a flight, a 2-hour flight or whatever, I'm going to pee just in case. But maybe just starting with like that side of things, like why is that maybe not ideal? And then also, I mean, you talk about like if we're, when we are going to the bathroom, we shouldn't be like pushing down to pee. Is that true? We're supposed to just like let it happen.
Yep. Yeah. That's true. Yeah. So
two things there, but yeah.
Peeing just in case is, again, a strategy that a lot of people will take if they are leaking or if they feel they have urges. So we can have stress urinary incontinence. This is where you leak when you laugh, cough, sneeze, jump. You can have urgency, and you can have urge incontinence. So urgency is like a sudden overwhelming urge and you feel like you can't make it to the bathroom in time. You might leak along the way, and that would be urge incontinence. You can have frequency. So people will often say, oh, I have an overactive bladder, or I have a small bladder, and they feel like they're going to the bathroom all the time. So people who are dealing with those conditions will often pee just in case, because they're like, okay, well, I'm going to my exercise class. I don't want to leak when I'm in my class. I don't want to have to leave partway through. So I'm going to pee before my class. Some people will leave partway through and pee again, and some people pee at the end. And so they're constantly peeing.
That's me.
Yeah.
That's totally
and
me.
That is then training the bladder to signal here as opposed to here. So a cup and a half of liquid-ish urine would be, your bladder can hold more than that, but generally a cup and a half of urine. I always joke, go get a set of measuring cups from the dollar store and don't put them into your kitchen. Just measure. If you have a cup and a half of urine coming out, that's a pretty good full bladder. But if you are peeing and it's like 3 seconds or 5 seconds and you're nowhere near a cup and a half of urine, you're training your bladder to signal you when it's not actually full. So you will put yourself in that path of having to go all the time. And a lot of people do this just at night, before they go to bed. Some people do it before, I guess, as you said, before you get on an airplane, before you go to your fitness class. But all of these then become triggers or signals like Pavlov's dog. So your bladder's like, oh, she's getting ready to go to her fitness class. That means we have to go to the bathroom, and it'll signal you, even though it's not actually full. So,
yeah.
And a lot of parents do this with their kids when they're leaving the house. They'll say, okay, time to go to the bathroom. And the kid's like, I don't need to go to the bathroom. Well, just go and try. Just go. And so that then is also setting the kids up so that they aren't listening to their own signals. And the bladder is then going to start to be the one in control rather than you being in control. So every 2.5 to 4 hours would be considered normal voiding throughout the day. If you have a huge volume of liquid, you're going to have to pee a little bit more. If you have bladder irritants like caffeine, like alcohol, you're going to probably have to pee a little bit more. So any of those irritants you would want to take out. But if you're doing this because you're like anxiety or feeling stressed or nervous about something, well, also it's a sympathetic nervous response. It's going to irritate your bladder. It's going to make you feel like you need to go. But we can dampen that. We can calm that signal down with mind body talk, with certain things like scrunching your toes, doing some calf raises on the spot, doing some pelvic floor activation and relaxation can help calm that, I would say, inappropriate urge. So if you know that you're feeling like you need to go, but you say, well, I just went 35 minutes ago, I haven't had a huge volume of liquid, you know you don't have a full bladder, but you just need to remind your bladder that it's not full because you've helped train it to signal you more often. Now you need to train it to not signal you more often, if that makes sense.
Yeah.
And then
so I'm not a lost cause. I can reverse
no, no, absolutely not. You can reverse it. You can reverse it. And that's something like you do want to take back control because that can be it interferes with a lot of things if you're constantly planning your life around your bathroom, right?
Yeah. I mean, like I love going to Disneyland or Disney World, and my husband is such a sweetheart. He knows I am going to pee before I get on every ride because I have this fear that I'm going to get stuck on a ride that breaks down and then I'm going to have to pee. And I've never had like leakage issues. Like that's not even a concern in my mind. I don't know why I'm so scared I'm going to pee my pants, but so I pee a lot. But then if we have friends that come with us, they're like, God, you pee a lot. I'm like, yeah. Okay. So this is something I need to work on.
I would because
you and I went to Disney together. We were not synced. You had to go and then I had to go. So we ended up going to the bathroom 20 times in the day.
Yeah.
Yeah. 5 to 9 times in a day would be considered normal. Again, and that's like if you're staying hydrated, if you don't have a huge volume at a short period of time, if you don't have irritants, if you're not constipated, that is what would be considered normal. With regards to the pushing to pee, that happens, it can be for a few different reasons. So sometimes it's people who are in a rush and they're just like, I gotta go. I'm hurry. I'm a busy mom. I've got to get to this meeting, whatever it is. And you feel like you need to push. And it could actually end up doing the opposite and slowing things down because when we urinate or when we poop, what should happen is the pelvic floor should relax and the bladder should contract to empty. And if the pelvic floor is contract, which will happen if you're trying to push, because it'll be activated with the muscles that you're trying to push with, this is not relaxed. The bladder then is like, come on, just relax, let go, and it may not empty completely. It may not empty at all. And then you may have we always have a little bit of residual, but you may have more residual. So pushing is counterintuitive. It's not going to speed things up, and it could potentially make things worse. It could also be because you have tight pelvic floor muscles. So again, when we sit down, the pelvic floor muscles should relax. But if our pelvic floor is chronically tight for a number of different reasons, and it can't relax appropriately, then you are going to maybe feel that sense of needing to push to empty. It could also be if you have what's called pelvic organ prolapse. And this is where the bladder, the uterus, or the rectum shift out of their proper anatomical position and they bulge into or descend into the vagina. I'm just reaching for the organs in my pelvis here, my pelvis model.
And why would that happen?
So if you think of statistically with incontinence, it's about 30 to 40% of women will experience incontinence. I think it's much higher than that, but that's statistically what we see reported. 50% of women who have given birth have some form or some degree of pelvic organ prolapse. So pregnancy and childbirth are major contributing factors, but you don't have to have been pregnant to experience prolapse. This could be from chronic straining from constipation, chronic coughing, poor posture, falls, previous surgeries, hysterectomy. Those are all contributing factors to, and that's not an exhaustive list, but those are some of the main contributing factors to the development of pelvic organ prolapse. So this is kind of, anybody who's watching on video, you can see this is kind of like textbook alignment of our organs. So here's our bladder with the urethra. the vagina, the uterus, the fallopian tubes, ovaries, and the rectum. So those are the three openings: the urethra, the vagina, the rectum. And in the case of a prolapse, so with bladder prolapse, the bladder can start to bulge into the front wall of the vagina. In the case of the rectum can bulge into the back wall of the vagina, and the uterus can descend from the top down. And so you get these bulges, you get a sense of heaviness, pressure. You might have difficulty with insertion. So some people will say, I feel like I hit something when I put in a tampon or when I'm having insertive sex. Or I put in my tampon, but then over the day it starts to get pushed out. Sometimes it gets pushed out even upside down. People who have chronic low back pain, difficulty voiding. So again, if you feel like you have to push, it can be that I don't have my sweatshirt here. I usually give a demo with a sweatshirt arm, but if you can see, this is the bladder. If it was bulging into the front wall of the vagina, it'll create like a little pocket where urine can get trapped. And the same thing could happen in the back wall. So if this is the back wall of the vagina and the rectum starts to bulge in, it creates a pocket where poop or gas can get stuck. So that means emptying the bladder or emptying the bowels can now become more challenging. And people will say, I just feel like I'm constantly constipated. I don't ever feel like I'm emptying completely. And sometimes the reason is because they have a prolapse. And again, if you've never heard that term before, if you aren't conditioned to seeing a pelvic floor physical therapist every year for a checkup, a lot of people have no idea. They excuse it away with other types of symptoms. So don't push to pee.
Seems very uncomfortable. Yeah. I'm kind of curious in this pushing conversation. So what about the opposite? So sometimes if I can't get to a bathroom for a really long time, it's like, oh, I gotta go. And then at some point it's like, I don't have to go. Where did the urine go? I'll sit down and it's like the bladder's or the pelvic floor is not naturally relaxing. One, I'm like, where does the pee go? But at that point, I feel like I have to push because my brain, I guess, knew there was no bathroom. And so then it told me I didn't have to go. Do you know what I'm saying?
Yeah. You're in this, you're guarding, you're ignoring the urge. And the bladder, as I said, the bladder won't explode if you have more than a cup and a half of liquid. The bladder can keep expanding. And at some point, it can only hold so much. And then you would have what's called overflow incontinence, where it would start to leak out just because there's too much. And it takes a lot to get to that point. And that could be somebody who has limited mobility, who actually physically cannot get to a bathroom. If nobody was there to assist, that could potentially get to that point. I'm not saying you're going to get there, but so over time, the signal you can ignore it and the signal will kind of go away. And then the bladder just kind of keeps slowly filling and slowly filling. It doesn't go anywhere. It just keeps slowly filling. And then when you sit down, because you've kind of been guarding and you sit down now to pee, the pelvic floor is like, but what is it okay now? Is it not? So it takes a minute for you to kind of relax. And that can be, even I mentioned posture. Sometimes people will sit down on the toilet and sit down sort of slumped and their pelvis is tucked underneath. So they're in that shorter, tighter state of the pelvic floor, not relaxing. So when we sit on the toilet, if you can sit, I always say like, be a proud pooper. But if you're going to pee, sit down, kind of think about your almost like you want to reach your sacrum or your tailbone behind you, have a gentle curve in your back, and then lean forward and put the backs of your arms on top of your thighs and hang out there. Take a breath in, let your belly expand. And as we take a breath in, that's when the pelvic floor also relaxes and releases and expands. So you might need to take a few breaths, but that's a more appropriate posture where you might be able to encourage that relaxation to happen.
Okay, I love that because I think naturally I'm like, relax, like curl into like a fetal position, which probably is maybe how Renee and I got into any kind of urinary issues in the first place as dancers. You tuck your pelvis under in ballet.
Yep.
And don't breathe.
And don't breathe properly. Like maybe you have some chest breathing. There's no diaphragmatic belly breathing. Your pelvis is tucked under. I'm sure 99% of ballet dancers have pelvic floor dysfunction.
It's true story. Dancers are in a high risk category. I shouldn't say high risk, but it's frequent. It happens a lot in that population. Equestrians, so people who ride horses a lot, Even sometimes yogis and Pilates. So we think of yoga as being very calm and everything's relaxed, but especially the cueing of Mula Bandha and a lot of core activation, there is a lot of holding, and same with Pilates as well. Not to say again that these are bad things, but without the awareness of having the balance between the effort and the ease, we all, like so many people interpret, if I'm leaking, I must be weak. Therefore, I need to hold and grip more so that I can strengthen. And part of the reason we leak can be because we already have too much tension. So if we have muscles that are too tight and short, they become fatigued. They lose part of their range of motion, so they can't react as quickly. They can't react at the right time. They can't develop the amount of force needed to close the openings off. So the thinking behind that is like, how, if I'm tight, I thought tight was good. I thought tight is strong. I think I want a tight vagina. But tightness interferes with blood flow circulation and doesn't allow for the appropriate reaction time and force development of the muscles. And if you are in an activity where there's an emphasis on gripping and holding, that can sometimes exacerbate that short, tight pelvic floor.
Yeah. Same as any
Okay.
major muscle complex in the body.
Yep. Yep.
Or
Right.
intuitively we think like, oh, something is tight, I should stretch it. But a lot of times it's the strengthening that we're missing. So it just applies across the board.
1,000%. Yeah. So we need to, yes, we need to work on nervous system. We need to work on posture. We need to understand, why are you tight in the first place? But tight is weak, and we do need to strengthen tight muscles. There was an interesting study that looked at, there's a pain category called vulvodynia, and it's a pelvic pain condition. Historically, somebody with pelvic pain, you wouldn't give them, Kegel exercises or pelvic floor strengthening exercises. But this study looked at, if, when we think of the reciprocal inhibition, if you really engage max activation, it actually elicits a greater relaxation response. And that was happening in this group. So I'm not one of the people that says, if you have a tight pelvic floor, you never are going to do Kegels or you're never going to do pelvic floor muscle training. We just need to have some nuance in there. We need to understand why you are tight and work on that. But then we also do need to take that muscle through the range of motion to encourage blood flow circulation, to remind it of the full excursion it has, and so that we are doing an element of strengthening because it has been weakened by being in a chronically gripped state.
That makes sense.
Okay.
Yeah.
Interesting. What are your thoughts on like a squatty potty for
Not squatty potty.
Okay.
Yeah.
Should we be using that for number one and number two? Or is that like the
More
ideal
so for number
position,
two.
Okay.
Yeah.
So for peeing, do the other thing that you said about how to sit.
Yes.
Okay.
Yeah.
Don't need to pull it out for that. Okay.
Not to say that, like, there are some people who may find that the squatty potty, that they use it for peeing as well, but generally it's more favorable. It's more favorable for poop, for your poop posture. And then for the pee posture, just feet on the floor and leaning a little bit forward.
Mm-hmm.
Okay. Okay.
Yeah, but I love squatty potty.
Okay, cool.
Yeah. Good posture on the toilet.
Yeah.
Yeah.
And it's not like,
I go to the bathroom now.
So the ideal posture, and it's funny, I have a lesson where I talk about potty posture and being a proud pooper. And it doesn't mean that you have to sit like upright, very rigid, but when you have your feet up elevated on the stool, on the squatty potty, I think it should be called the stool, but you've got your feet up elevated and your knees are bent, and you sort of like, I wrap, almost like I hug my knees, not in really, really tightly, but I wrap my arms around my knees. And when you take a breath in, as I mentioned before, the in breath is when the pelvic floor relaxes. Physiologically, in breaths relax the pelvic floor, exhales contract and lift the pelvic floor. So knowing when we poop, it's an elimination. We want the pelvic floor to relax. So we get into that position where our knees are elevated, wrap my arms around, I take a breath in, my belly also presses in against the tops of my thighs. That pressure in and of itself can also help with the bowel movement. You take a breath in, and that's actually, like, people think of pushing to get a bowel movement out. We should actually inhale and allow the body to get it out rather than us pushing and straining to get it out.
Mm-hmm. Mm-hmm.
Okay. Okay. Yeah. I think a lot of people are pushing and straining. So
yeah.
Wow. Okay. So like you mentioned, even like with Kegels, like that seems like a very personal thing, like whether you should be doing it or not. And so in the realm of if someone has pelvic floor dysfunction, do they need to go see a PT? Is like that where they get started to see like personally what's going on? Or are there things that all of us can be doing, with your resources and exercises at home? Or could you do more harm by not following a personalized program?
I mean, it's a little bit nuanced in there. I wouldn't say it. So yes, gold standard. I think every woman would benefit from seeing a pelvic floor physical therapist once a year, even if you have no symptoms. Just like we go to the dentist. I know you guys are, your father is a dentist. So we've been conditioned from a very young age. You go see your dentist once or twice a year for a checkup, right? We brush, we floss, and we go to see our dentist. And we go, even if we don't have anything achy or bleeding gums, we just go. And if we had that same PR for our pelvic floor, where we've had somebody teach us pelvic floor exercise, and our pelvic floor muscle training is basically our brushing and our flossing, and then we go see our pelvic PT once a year for a checkup, I think it would change the world, literally. So yes, that's gold standard. That doesn't mean that you can't make progress or you can't be successful with, an at-home pelvic floor muscle training program. So there are some biofeedback devices that I'll talk about. I have a whole body fitness program that people can learn from. My approach is very much visualization, cueing, so that people can access this group of muscles that we can't see. Like we can see our external genitalia, but we can't go to the mirror and flex our bicep. We can't flex our pelvic floor like we do other muscles and see it. So we need some visualization and some cueing to help us activate this group of muscles. The challenge again is we don't even know it is a group of muscles, and no one's ever taught us about it. And it's not usually until we have a problem to overcome that we start thinking about it. Now we feel shame. On average, women wait 6.5 to 7 years before they even go get help because they're embarrassed, they're ashamed, they don't want to embarrass their care provider. Like there's all these reasons. But a lot of people can have really good success with the right guidance and cueing and education on posture and that type of scenario. The nuance would be in there is, if somebody comes into my program, let's say, and they say, well, I feel like my symptoms are getting worse within the first couple of weeks, and they haven't seen a pelvic PT, then either they're not doing it correctly, or they may have tension in their pelvic floor, and they may need the nuanced approach that I have a section in there about what to do if you have this, what to do if you have this, where it would be you would change your breath slightly, you would change the way that you activate, and you would focus more on the release work. So there is some nuance that can be beneficial, but for the most part, once you come in and learn the foundational lifestyle principles and the foundations about posture and breath and how to activate your pelvic floor and coordinate it into movement, most people, again, I'm biased, go see a pelvic floor PT, but I would say the majority of people can make a lot of progress without seeing. You don't have to see a pelvic floor physical therapist in order to have success with pelvic floor muscle training if you are doing it correctly.
That's awesome. Okay. I like that, because I do think this still falls in the prevention category, but also, like the things you're doing every day at home, like proper breathing, like you said, or stopping the maybe peas, or what did you call them tonight? The just in case
peas, in case, or the worry peas.
Yeah.
So I was having some back pain, and part of my PT was getting some pelvic floor therapy because my my obturator internist, was really tight, just on one side. I don't think I could have released that on my own.
That would be a difficult one to do on your own. Yeah. So, and the obturator, yes.
Yeah, it's in there. So
yes, it's really, really deep. And so 95, this is one Canadian study. There's several studies that have confirmed a link between back pain and pelvic floor dysfunction. So over 95% of women with low back pain, chronic low back pain, have some form of pelvic floor dysfunction. And again, there's that missing link of we go to massage therapy, we go to chiropractor, we go to regular physio, and we're chasing all these therapies, which I don't want to say are not beneficial. They can absolutely play a role, but so often the pelvic floor is the missing link, and usually it's tension related. Most of the time, if somebody is experiencing pelvic pain, painful sex, pubic joint pain, tailbone pain, hip, back pain, it's usually tension in the pelvic floor. And it is very common for it to be one-sided versus both. And that could be posture. It can be, a dominant side. It could be because of an injury. It could be because of scar tissue from a previous injury or surgery. It can be from lots of different things. But the internal assessment therapy intervention is really valuable. But that being said, there are things called pelvic wands that you can get, that you can use. So again, somebody who may not be able to see a pelvic PT, or maybe they can, it's 4 hours away, they go once and they've got the information and now they're going to self-manage at home. A pelvic wand is like an S-shape device, usually made of silicone. One side is like, one end is usually a little bit more pointed. The other end would be a little bit more round and bulbous. And these would be inserted into the vagina. And you, as you're holding it, you're pressing, mobilizing tissue. You find trigger points. You're helping release, just like you could apply pressure on a knot in your neck or anywhere else in your body. So those are things you can use from a self-care perspective. There's also a couple of red light devices that are used intravaginally as well. So one is called, by the company is Joylux. It's V-Fit in the United States, or V-Sculpt in Canada. Yeah. And it has red light, infrared heat, and vibration. There's another one called Fringe. The company is Fringe Heels, and they have a wand as well that has red light, also has blue light, also has vibration, also has infrared heat. The benefit of those is the heat is, first of all, soothing. The vibration can also help elicit a relaxation response. On the flip side, if somebody maybe didn't have pain or didn't have tension, if they were using one of those wands, similar to vibration plate training, where we know we're getting more activation of the muscles when we're in the presence of vibration, we insert a device that's vibrating and we do our pelvic floor muscle training in the presence of that vibration, can help increase blood flow and get a little bit more activation as well. So I'm a huge fan of red light in general, but specific to the vagina, it's really helpful for blood flow, circulation, relaxation, activation. And also, as we're approaching and moving beyond menopause, we need to help the tissue with collagen production and lubrication. And there's been some nice research looking at how that can help with vulvovaginal atrophy, now called genitourinary syndrome of menopause.
Amazing. I love that we're putting red light everywhere. Like,
great. All over.
I know. I
had all parts.
Yeah. I now have a red light face mask. I have intraoral. I have a handheld. I have full body.
Now you're going to have a vaginal one.
Oh yeah. Nasal. I have gut brain access. I have, I'm missing the V-Fit. That's the next thing.
Yeah.
Well, so kind of funny, interesting story. I was out to lunch with 2 female biohacker friends a couple weeks ago, and we were talking about pelvic floor. Because what do you talk about when you're out at lunch with your girlfriends?
Yeah.
And they both have 2 children. I don't have any kids, but one, she just gave birth to her, and she listens to the show. So hi. She was telling the story how she just gave birth to her second child like a month or 2 ago. And it was basically like 2 pushes, no tears. She was working with a pelvic floor therapist before, and she was just like swearing by it. Like it made such a difference. And then the other friend was not even aware of this idea. And she did have a tear, and she was like, your PT put their finger where? And she's like, well, she had a glove on, and it's kind of a funny, like, girlfriend lunch. But I'm
1,000%.
Like, before or during pregnancy, like that makes so much sense, because you're about to go. I've never, gone through labor, but it sounds like it's quite the experience.
It's a process. Why would you not? That's how, when I first how I got into this work was because I was afraid of childbirth, and I saw my mom experience issues, and I grew up thinking I'm never going to have children. And then I got married, and then it was kind of like, well, maybe. And then I watched my sister-in-law give birth. And that was my first introduction to birth differently than what we see in the media. What we see portrayed in the media is not what I would consider normal physiological birth. So she was birthing in a sideline position. She was assisted by midwives. She had no tearing. And so this was sort of like the first, I was like, oh, I didn't even know you could give birth that way. And so that was a big turning point for me. The following year, I'm pregnant. My midwives tell me about a biofeedback device called the Epino. And this is a German device that is basically a silicone balloon that is inserted into the vagina. and it's attached to, it looks like a blood pressure gauge. It's attached to a pump. And once it's inserted, you add a little bit of air. And then when you do your pelvic floor activation and relaxation, you can see on the gauge if you're contracting and relaxing. Similar to the more modern versions now of like the PeriFit and LV, the biofeedback devices we see marketed to us on Instagram, which can absolutely have some value. Where the Epino also now kind of goes a step further. Epino, the terminology is no episiotomy. So episiotomy is where they would cut into the tissues, intending to create more space for mom and babe. We now know that that was creating more issues. But anyway, that's where the name came from. In the final weeks of pregnancy, you've been doing your pelvic floor muscle training, but in the final weeks of pregnancy, you now do an additional 10 minutes of perineal massage. So you have the balloon inserted, you inflate it to the point where you feel stretch, a little bit of discomfort, and you hold it there. And the intention is for you to build awareness of what you need to do to find ease in the presence of discomfort. And over that 10 minutes, you might notice that that sensation will start to soften, and then you can increase it a little bit more. So you're training the muscles to learn to relax, even though you feel like, that's painful. I want to retract from that. And then you, ideally, you relax enough so that the balloon can come out of you inflated. So it's trying to, as close as possible, mimic the sensations and the process of birthing without actually giving birth. But so
that's very cool.
That's how I started. I used this product and I thought, why doesn't everybody use one of these products? And I contacted the company and said, hey, could I sell these to some people in Canada? So that's how I started. And coming back to my point is that that's where I started, very much in the realm of prevention. Like, if we could get this information to women ahead of time, before they give birth, knowing pregnancy and childbirth are such major contributors to pelvic floor dysfunction, why are we waiting until afterwards? And then I didn't even know about pelvic floor physical therapy at that time. And then probably maybe 3 years after I started selling it, I had a website. I started having people say, my pelvic floor physical therapist recommended it to me. And I thought, what the heck is a pelvic floor physical therapist? And then when I learned what they did, I thought, oh my gosh, now I have to yell about this from the top of the rooftops as well. And then many of them started to become more trained in in birth. And they were almost being like a doula, where they were assisting sometimes actually in the birth, but even ahead of time, working with people in different birth positions. So side lying, tall kneeling, squat, standing, like staggered stance, the common birth positions, and helping that person identify, your pelvic floor relaxes really well in this position. You have a harder time relaxing in this position. So that person then goes into their birth feeling really empowered, knowing that their pelvic floor, that they can connect with it, and they feel confident that it's going to respond appropriately during the whole phase, during the push phase especially. But then afterwards, we can't just, like, I looked at that and said, okay, well, I'm doing all this work to help people prepare, but especially in North America, we now are just like, high five. If you birth at home or if you birth at a hospital, you're out within, very most 24 hours, and that's it. And you now have to keep this baby alive, but you've also been through this huge, arguably, trauma to the body, and you have no direction. And if we had had an ACL repair, if we had torn a shoulder, we would have a full protocol given to us about recovery. And we get zero from a pregnancy and childbirth recovery perspective. And then we have this society that applauds people. Oh, you don't even look like you had a baby. Oh, you were back at the gym already. Good for you. And we don't honor the need to recover and to restore and to retrain that whole deep core system. So your pelvic PT is also going to be a part of that. And I think they should be the ones who give you the green light to go back to your regular activities. Many people now when they wait 6 weeks, they go see their doctor. They don't even have any sort of internal evaluation. They just like, how are you feeling? Did the scar heal? Yeah. Okay. All right. You're good to go. And I just feel like that's not okay. We need more of those pelvic PTs involved in the process the whole time.
That's pretty scary, because probably a lot of times people are trying to get their body back. So it's more of like an aesthetic achievement rather than paying attention to what's happening on the inside. And if your all of your core is not activating, we're going to get injured, right?
Yeah. And it of course it's not going to be like when you really appreciate all the change that has happened over that period of 9 months, there, of course, the whole core system is going to be hindered. The muscles have stretched. Diastasis. So we have the two rectus muscles are further away from the midline. That connective tissue has stretched. The muscle bellies themselves have stretched. Our capacity to generate intra-abdominal pressure appropriately, or to manage pressure, is changed. And that's okay. It's not that it's a bad thing, but we need to, first of all, have the awareness of what to do during pregnancy, but also in that period of recovery, what we need to do to help retrain that system. Going back to, normal at 6 weeks postpartum, there's a fellow named Paul Chek, who I love. He's a movement professional, and he has
that's how we got started in the
Yes.
world of health. Paul Chek. Love him.
So Paul we were in a presentation with him once at a fitness conference, and he said, it's like trying to launch a cannon from a canoe. And so a postpartum body is kind of like this canoe. And when we're going back to the gym and doing higher intensity sometimes, because now we are like, I want to lose the baby weight. I want to feel strong again. When we haven't developed the capacity within that deep core system to manage the pressures, it is literally like trying to launch a cannon from the canoe. So we need to get the canoe more stable, or get onto a more stable platform before we start launching the cannons.
Yeah, that's one of my favorite Paul quotes. It just makes so much sense.
Yeah.
I hadn't heard
the Tech
that.
Institute, I think, does a really good job of teaching these concepts that are not in traditional fitness training programs, but still feel like we have a long way to go. And I think women just really more readily need allies for this. And I think, as you said, like that should be the checkpoint to, can you resume normal activity?
Yeah.
I'm curious, with a vaginal versus C-section birth, what are the differences and changes to the pelvic floor that you've seen?
Obviously there is some protective element if somebody has a cesarean birth via versus a vaginal birth, especially like tearing is very likely. It's very common. There are some things you can do to reduce the likelihood, but it is very common to experience some tearing, at least. More severe tearing, like 3rd and 4th degree tear, it's now becoming a little bit more mainstream that those are always now being referred to pelvic PT. I argue every single woman should be seeing a pelvic PT, but especially if you've had a 3rd or 4th degree tear. It's called OASIS, obstetric anal sphincter injuries. So there's a movement called OASIS where they're trying to bring awareness about that. If you've had a cesarean birth, there are some people who have elected to have a cesarean birth, and there are other people who have gone through labor. Maybe they've even pushed, and now they're having a cesarean. And that person is arguably going to have more challenges than somebody who just had an elective to some degree. Mm-hmm. But there was one study that looked at 6 weeks postpartum, 83% of women have some degree of prolapse. This is looking at vaginal and cesarean birth. 83% of women have some degree of pelvic organ prolapse. 52%, I believe, of that group had a stage 2 or greater, so a more moderate pelvic organ prolapse. It's super common. Nobody's screening for it. So we think that if I have a cesarean, my pelvic floor is fine. But I could argue you might even be more compromised, especially if you have gone through pushing, because now you've had, in a cesarean, you have multiple layers of incisions down to be able to get babe out of the uterus. Multiple layers of adhesions are now created as we sew up all of those layers. You've had the same postural adaptations, same hormonal influence. You've had the same stretch to all of the kind of core, deep core system. And now you have this scar tissue that is coming in and really interfering with function. So it's very common, especially in the cesarean population, to have pelvic pain, painful sex, very tight pelvic floors afterwards, because there's been a huge disruption to that core control system. So everything's kind of like scrambling and jumping in to try to save the day. And we often get overactivity in many parts. So yes, those people are not going to have a 3rd or 4th. They're not going to have any vaginal tearing. That doesn't mean that they are going to be immune to pelvic floor dysfunction.
Okay. Interesting. Wow. One other thing you had mentioned when the abs kind of split,
Diastasis, yeah. Diastasis or diastasis.
diastasis, how common is that for women?
We have some research to show that pretty much 100% of women in pregnancy will experience it's considered a normal adaptation to pregnancy. The
Oh,
challenge with diastasis or diastasis, however you want it, it's like Kegel or tomato. In the rectus muscles, actually have a diagram here. So in the rectus muscles, so here's the pelvis, okay? Here's the pubic joint, and here's the sternum. And these are the two six-pack muscles, the two straps. And this connective tissue in the middle is called the linea alba. The linea alba it means white line. And that connective tissue holds the muscles in place, but the muscles are never fused together. There is always a gap there. And most people learn about diastasis after they've had a baby. They never had their gap measured before. And when they measure it after, that might be the same size gap you had before. And we don't really have any research to say what is considered a perfectly normal interrecti distance, the space between the two rectus muscles. So the terminology is a little bit misleading, maybe. What is more like, and for a long time, research would focus on the size of the gap. And that was and if you look at a lot of things on the internet are all about closing the gap. We need to close the gap. I mean, maybe narrow to some extent, but it's not so much the gap, it's about the integrity of the connective tissue. Some people may have 3 finger widths, 4 finger widths, 5 even. But if they can generate and maintain tension in that linea alba, their function isn't necessarily hindered. So there's more research is now evolving, looking at potentially categories of interrecti distance plus how much distortion or lack of control is there in that connective tissue, because it's not really about the gap. And a lot of what we see on the internet is about safe and unsafe exercises, and you can only do this to close the gap, but you can't do this. And I feel that's a little bit misguided, especially based on more research. So very common, considered a normal adaptation. It's not like people think you can't do crunches, you can't do planks, you can't do twists, you can't do this, you can't do that. That's where, 15, 18 years ago, I was in there too, thinking, no, we can't do these things. But now, thankfully, we're way on the other side. And it's not as catastrophic, I think, as a lot of people think that it is.
Okay. Especially because all of those boundaries create so much fear around that. And you said this in the very beginning. We start telling women, you can't do this, you can't do that. And then it's like, right, create tension and fear. And I feel like that's going against what we're trying to work so hard for.
Right. And we found that, at the beginning, we didn't really have a ton of research. And at the time, I'm a personal trainer, and I did have a business partner who was a pelvic PT. A lot of what they were told, we were sort of going along with what the pelvic PT world was saying. And that was very restrictive at the time. And what we then found was, as we were starting to say, we need to push these boundaries a little bit more, we had people that we had now created bigger compensations. They couldn't get off the floor properly. They couldn't, because we had limited movement so much, they now were weaker, and we're like, this is not okay. So we need to develop the capacity for all the things, all the movements, all the strategies. We just need to look at, like, what cueing do we need? What visualization? What breath strategy? How do we use principles of fitness like progressive overload? Rather than, can't be, Mother Nature is smarter than to say, after we've given birth, you can't do all these things. That's just not the way that we're going to evolve, right?
Yeah. You're done.
Yeah.
You're done.
Yeah. Yeah.
That would be crazy. Yeah.
Yeah. And that's kind of, I would say, like, when you think about kind of how, like, where my method came from was really bringing fitness principles and applying it to this group of muscles called the pelvic floor. And we can't just think of 3 sets of 10-second hold Kegels is going to be enough for everybody. First of all, that's not going to work for every single person. We need to have some nuance in there, but we need to address things like posture, like pee pushing, like peeing just in case, like constipation. But then we also have to apply real life movement at the gym where we know the pelvic floor is part of that movement strategy. So how can we leverage that? How can we train the pelvic floor as part of a whole body movement practice so that we don't have to just have this pelvic floor practice and are the things we can do the two together.
Yeah, integration is so huge across all health principles.
Yeah.
Can you tell us about the Buff Muff Method? How is that so hard to say? Buff Muff.
I know. I get buff muffins. Like people, it's the typo, right? So I feel like I need to make a buff muffins recipe. But
Oh my God.
the buff muff. So how that came about was I had created this 28-day challenge. At the time, my program was called Kegel Mojo, and there was this 28-day challenge, and I started to say, come buff your muff, and then everybody loved that. So anyway, I changed the name to Buff Muff, and yes, it's funny. Yes, it's haha, and I like to have a little bit of humor with a very heavy topic. It's hard to talk about. We need to have a little bit of laughter, but I want this to be like we should be okay with feeling and being strong and doing things that will enable us to be strong as we age. And knowing that so many people stop exercising, knowing the link between pelvic floor dysfunction and the risks of falling and hip fracture, osteoporosis, like we need this group of muscles. It is so, so important to our vitality, to our quality of life, to how we age. So I wanted people to appreciate that it's so much more than Kegels, that all the ways that we can strengthen our pelvic floor also help build our bones and our hearts and our brains and our, all the things. But we're doing it in a fun way as well. So I didn't want this to be another thing on the to-do list. I wanted to make it's workouts. So if like ideally you're already working out, now I'm just going to teach you a way to work out that's also going to help leverage your pelvic floor and make sure that it is not kind of just left to the side. Because we do know high intensity exercise without that education can lead to challenges. And it's not to say that you can't overcome those, but if we can intervene earlier on, we're going to set ourselves up for a smoother transition through perimenopause, menopause, and be less likely to end up in a nursing home. Incontinence is the second leading cause of admittance to nursing homes. And that doesn't mean
Wow.
if you guys started leaking, that doesn't mean you're going to go live in a nursing home. But if you have somebody who's older, who's needing some additional care, family members are okay caring for them until continence issues are in the picture. And they're like, I'm tapping out, not for me. And that's when you're going to go on. So if we can come in and intervene, and just one final thing on that is a few days ago, July 17th, there was a panel invited to the FDA. Vaginal estrogen is a gold standard, well-established, very safe, very effective, I could argue, be handed out like candy to women from menopause onwards, potentially also women in postpartum, or if you're dealing with symptoms earlier on. And there's a black box warning currently on the packaging that is not medically accurate. It will say you are going to get possible dementia. It says you're going to have a heart attack, blood clot, stroke, cancers, and there is zero evidence to any of that. And so thankfully, the FDA finally held this panel and had incredible presenters talking about research on not just vaginal estrogen, but hormone therapy in general, or women's health in general. But I say this because vaginal estrogen is so important for the integrity of our muscles, the tissues within our pelvis, our vaginas, our vulvas as we age. So if you're listening to this and you're in your 30s and 40s, if you're in perimenopause, or even if you're postpartum and you feel vaginal dryness is an issue or painful sex, speak to your care provider about vaginal estrogen. And also know that once you reach your menopause, average age 51, but that could happen sooner or later, ask your doctor for vaginal estrogen, bioidentical vaginal estrogen, and this is something you will stay on for life. It's so, so important. Genitourinary syndrome of menopause is genital symptoms, sexual symptoms, urinary symptoms. So urinary frequency, urgency, burning, UTIs. UTIs are incredibly common, especially post-menopause, especially if somebody has already been dealing with recurrent UTIs, and they can become septic, and it kills many people every year. And so I want to urge people to not be afraid of vaginal estrogen, and please use it because it is an essential part of vulvovaginal health as we age.
Mm,
I've
thank
started
you for saying that.
experimenting a little bit. I don't think I'm at the point where I'm like, oh, I need it, but I want to prevent. And I'm like, use a little bit
Yeah.
down there. I would use a little bit on my face. I'm like, it's all just in one pump.
I was gonna
Yeah.
say, is it the same? Because like I have just like a topical, yeah, that
No,
sometimes I put on my face. I
no,
shouldn't.
no,
No, okay,
no. You want to get the
okay,
stuff that, first of all, there's the dose that will be different, and also the ingredients. We need the ingredients that are suitable for the pH of the vagina, and the osmolality. So the
okay.
things we put on our face are not meant for our vaginas. And when what we use in our vaginas, yes, you could put on your face, but it's not really going to do very much. So, um, and the other point on that is, don't wait until you have the symptoms. We know that upwards of 80% of women will experience one or more of the symptoms of GSM. Don't wait until you know that this is just kind of like, I consider it like an essential nutrient from the time you're menopause and onwards. It's just what you do. So starting earlier is totally okay, but also just say, well, I don't really need it yet. But if you're around that age, if you're approaching that age, or if you have symptoms, then use it freely.
Yeah. Great.
Okay.
Okay.
I'm all about prevention. I'm like, you've given me a lot of food for thought today. So it's been amazing, Kim. And I know we really just, I think, scratched the surface. I learned a lot. I took a ton of notes, but I think this is just the beginning of the conversation. So for our audience, if they want to get started, learn more, where can they follow you, learn about your courses, your podcast, all the things?
Mm-hmm. Yeah, thank you so much for the conversation. And my website is vaginacoach.com. All of my social media handles are at Vagina Coach. I do have some free content on my YouTube channel. Go to Vagina Coach on YouTube. Instagram is typically where I hang out the most, at Vagina Coach. My podcast is called Between Two Lips, and we cover 95% is pelvic health related. There's the odd conversation there that is more overall women's health focused. And then I would just say, if you take one thing away, go see a pelvic floor physical therapist. And how you would find one, you can use Google and just put in pelvic floor physical therapy. If you happen to live elsewhere in the world, sometimes it's physiotherapy or women's health physiotherapy or women's health physical therapy, and your city or the closest major city to you. You can also look, there's a directory at pelvicglobal.com. And the American Physical Therapy Association has a directory. Canadian Physiotherapy Association has a directory. So there are some kind of national organizations as well. But I always say Google's usually where I start for the first step.
Wonderful. Thank you for making that so easy and accessible.
Yeah.
Kim, you're amazing. Before we wrap up and let you go, can you share one piece of advice with our audience, something they can start doing today, besides Googling where to find a
So drink more water, not less, if you are dealing with urgency or frequency. And if you are experiencing those anxious urges, you can scrunch your toes and you can do some calf raises and some pelvic floor activations in that moment to help calm that signal.
I love that, because I just learned just to do sort of the breathing. If I thought I had to go, breathe and do the contraction. But I like do all at once.
You don't have to do all at once. No, like scrunching your toes and trying to do calf raises isn't going to feel very good. So you can try one, like maybe it's just scrunching the toes. Maybe it's calf raises. Maybe like you could scrunch your toes and do pelvic floor. You could do calf raises and pelvic floor, but try each individually first and just see which one helps you.
Yeah, very cool. It's definitely helped me a lot to avoid the just in cases.
Yeah.
Yeah.
Good. Awesome. Yes. Thanks so much for having me.
Yes, thank you.
Thank you so much. And thanks to everyone for tuning in. We'll see you next time.